Okay, so we're going to start this again. And then again, like I said, I'll fully introduce myself. Then we'll turn it over to Allie and Jen. We'll turn it over to Pat after that. So please introduce yourselves while you're there when you come on. Just to give you kind of an overview, as Allie is with the Salt Lake County Health Department, Pat is with the Salt Lake County Fire, or Salt Lake City Fire, as a community health coordinator. So talking about all things falls prevention, as again, it is Falls Prevention Week starting off today, and falls is the leading cause of trauma. We don't like that. So I'm going to share my screen again. There's no sound on my screen. And hopefully now this is recording. I'm going to make sure that the view is the way I like it for that. So again, my name is Jamie Troyer. I am one of the trauma injury prevention outreach coordinators for the University of Utah Health. We are lucky enough to have two. Ruth is on the call as well. So Ruth is my partner in crime. I am a nurse by trade. My background is EMS and emergency department. And then I came into trauma. So I've been doing this for longer than I'm going to tell you guys. Of looking at falls, of injury prevention, I feel like has been part of my job for a very long time. I tried not to steal too many, this is my next one I fit. So one thing I heard this when I was talking to one of my gals in a national meeting, that she teaches a mindfulness class, and it is specific for falls prevention. And it's talking about how mindlessness can lead to unintentional injury. So letting that kind of sink in, knowing what people are talking about as you look at even just walking around your house, if you're not seeing hazards. I talked to a lady today that she forgot where she was going, even though this is a place she'd driven to multiple times. And we talked about, especially, and she was an older adult, how our memory likes to go as we get older. And probably just thinking about other things in her car where she had to pull over and ask for directions, even though I think she had driven to that same place earlier that week. So being very mindful of what we're doing, paying attention to hazards, specifically for falls as we're walking down the street, walking through our home. Ruth and I talk a lot about, both of us have multiple dogs in the house. And so knowing where they're at and not tripping. But I really liked this quote of thinking that, yes, and it's not that people are mindless, it's just that we are so distracted. Our mind is full instead of being mindful. So that's where it comes to mindlessness. All right, so got to have statistics. I tried not to grab too many other statistics that maybe Allie or Pat might be sharing with you. Falls does not just affect older adults, but it is the number one cause of fatal and non-fatal injuries among 65 and older. It is also the number one cause of construction worker fatalities, and most of those are falling from a height. You also have 30% of adults with intellectual and developmental disabilities that fall each year. And one thing I like to let you guys know about that is that the injuries from that can actually cause it to where they can no longer live independently if they were living that way before. So you've got to think about that. And then children ages 14 and under are treated annually at hospital emergency rooms. This is 2.2 million, ages 14 and under. For fall related injuries, 100 children die each year, at least, from fatalities from falls. You have ones that are falling from windows, playgrounds, all those different things. We don't see a lot of children at obviously the University of Utah Health, so I don't have exactly statistics on all of those for Utah. But thinking about this is I like to give a good picture that falls do not just affect older adults. Falls affect anybody. Falls, again, we get a lot of falls from height. We get a lot of falls off ladders, especially coming into the holiday season, which I'm sure the fire department can talk about as well, about how often they are going on ladder falls, or people that are up on a roof that probably should not be up on a roof. And you can see the statistics that I've gotten from today are from the CDC, Stanford Children's Health, the National Council on Aging, and then the National Save Kids campaign. Coming from the University of Utah for our stats, and again, we're just one hospital in the county. And knowing again that falls is the number one cause of trauma and injury across the globe. It's not just across the country, it is across the globe that everybody's trauma stats are showing falls as number one. But last year we had about 2150 trauma patients. About 33% of those were falls, were activated as a trauma. And our average is about 40% each year of our trauma activations are falls. And again, that's not just our older adults. You can see that again, the countrywide statistics that we have other causes of falls and injury that we want to take a look at. So this is the biggest thing for our healthcare providers of looking at what are the contributors to our fall risk. Why do we care? Like, especially my focus today is going to be emergency department screening. I feel like once somebody is admitted to the hospital, there is a focus on this, right? We want to keep them from falling in the hospital. And we do screen them, I think, a little bit more thoroughly if we feel like they're a fall risk at home. But what in that fast-paced environment of the emergency department do we need to think about? Because a lot of people get discharged from the emergency room for the emergency department and they go home. And unfortunately, they come back for falls. So it might be a headache that they came in for. But if we're not looking at those risk factors for falls and giving them that information, then maybe we're not helping them. We're not making it so they will fall, so of contributing to that fall risk. But it's really important that we're helping them. So the biggest thing that I say, especially in the emergency department, is lower body weakness. We see somebody get up and walk to the bathroom. We might see them walk into triage. And again, I spent 13 years in the ER. So looking at this and knowing kind of where that screening is looking at, do they have lower body weakness? If I'm noticing that as they're walking to the bathroom, do I need to put them in a wheelchair? And is it not due to the injury? So they didn't break their leg? Because of course, I'm not going to pay attention at that point in time. But that's something that's going to be a trigger to me is I really need to pay attention that they might be a fall risk in the emergency department, but also when they go home. Difficulties with walking and balance, same type of thing. We're visually watching them walk into triage possibly, or get up and walk to the bathroom, or seeing that kind of thing. So I want to pay attention. Do they have that difficulty with walking and balance? We're looking at their medications. So as they come into the emergency department, even when you're triaging them in EMS, you're looking at their medications. So do they have medications that are tranquilizers? Are they sedatives? Are we concerned that those medications, especially if they have what we like to call polypharmacy, if they're on multiple medications, we might not always know what's going to interact with each other, but we're going to be able to be concerned that, hey, you're on 2 different sedatives or something like that. We need to look at you for a fall risk. Vision problems, obviously vision changes for everybody. It's really important that we're looking at, do they already wear glasses? Do they have balance problems? Do they have lower body weakness? Because most of these contributors, it's not just one that causes a fall. It's a mix of a lot of these. Foot pain or poor footwear, obviously we're thinking about these. And then the fire department's going to be looking more at those home hazards, such as broken steps, throw rugs, as they're coming out to that. So just thinking about this, what's our contributors to fall? I want to talk about the myths. So this is from, again, the National Council on Aging, talking about the 10 myths that we should probably be thinking about of what's a fall. And again, all of these myths don't happen. We're not going to be paying attention to that initial visit, maybe that emergency department visit. But everybody falls happen to other people. It's not going to happen to me. I mean, people grow up saying that it's going to happen to everybody else. It doesn't happen to me. Well, guess what? 1 in 4 older adults fall every year, and less than half of them tell their healthcare provider. All right. So I think in that thought of like, oh, it's not going to happen to me, or I'm not at risk for falling, even healthy aging adults are at risk for falling. And if they're not talking to their healthcare provider, they're not telling people they're going to fall, I think it's more because they think that they're going to lose some sort of independence by admitting that they've fallen. But falling once also doubles your chance of falling again in the future. So it's not a normal part of aging. People think, oh, I'm not active at home. So if I'm not active, I won't fall. And that's also a myth. Muscle strength and flexibility cannot be regained. I think is when you see in the hospital, a lot of people use what's called a frailty score. Is that frailty score can change. You can increase your muscle strength. You can increase flexibility. If you do screen somebody that's at risk for falling, you should be asking them, to be taking a falls prevention class or strength training and explaining to them that it is something that is helping them. Multiple medications, we already talked about this. Using a cane or walker will make me more dependent, when actually, no, using your cane or walker might make you feel old, but it's actually going to make people be more independent because they're able to use that assistive device. And for our EMS folks, if somebody has an assistive device at home or when you respond to a crash or anything like a cane or a walker, please bring it with them to the emergency department. One, because they're used to that. It's fit right for them. Hopefully, they're used to that cane or they're used to that walker. So being able to have something that they're used to, give them that independence to move around while they're in the hospital is actually very important. And again, talking to the healthcare providers about risk. It's one of those things that I think we glance over sometime of, oh, you're a fall risk, oh, you're not a fall risk. But then what do we do about it? So again, looking at again, I don't need to talk to my parent or spouse. Yes, everybody should be talking to their family members about risks of falling, especially if they have any of those risk factors. And again, it doesn't just have to be an older adult. All right, so I'm going to share with you guys. It was a fall risk clinician survey. So it was a fall clinician survey by the Trauma Centers Association of America. And this is just part of the survey that I felt is applicable to what we're talking about today. So I would love everybody to put in the chat, if you're working in a hospital, what screening tool do you use? And not inpatient fall risk, but working in the emergency department. And obviously, if you do work inpatient, I'd love to know that too, is what screening tool do you use to assess fall risk? I didn't want to do this as a poll because I can't share everybody's answers, but if you're putting it in the chat, I can see that. In my career, I started out using the Morris Fall Scale. And then I know that looking at our facility, we now use the Johns Hopkins. So I would love to know, what screening tool do you use? And the next question I would like to ask, so the MedFrat is along the bottom there. Your brain risk assessment is more, it's more based on, are you at risk for a pressure ulcer? So I don't think that is really a good tool for falls. But again, thinking about some of these that don't make sense for that initial visit or that emergency room visit. And then how many of you guys received training on your falls risk assessment tool and why it's important? Or was it just said, hey, this is part of our survey stuff. This is something we have to do. You have to check all the boxes or you can't move on in your electronic medical record. But really, what did you use for training? So again, I'd love for you guys to put that in the chat. And I can't see the chat, but hopefully, Ruth, if there's anything I'm missing or you're seeing on there, please pop in and let me know. Second part of that is discharge referrals. So if you identify that somebody's at risk, what do you do? Do you know what referrals are available? Do you know what resources are available? And again, this isn't from the hospital, so you don't always have case management who sometimes is discharging the patient. You don't have some of those other resources that usually will discharge somebody from after being admitted. I really want to focus on the emergency department. If you identify somebody that's a home fall risk, what do you do? How do you get there? What kind of resources do you give them? In the University of Utah Emergency Department, luckily there's a physical therapist in there. So that's a great resource to identify somebody that's a fall risk and come to them with resources. I also put out resources in the waiting room there. So that kind of thing. But again, what discharge referrals are provided? Do you know what they are? Do you know who gives them? And talking about, a lot of times I think people don't really screen, because at the end of the day, it's like, well, if they screen positive, what do I do? And I think a lot of people are like, well, if I don't know what to give them, if I'm going to screen them positive and say, hey, by the way, you're a fall risk, but I don't have any resources to give them, that, to me as a nurse, I hated that. I hated being able to say, yeah, you've screened positive for this, but I don't have anything to help you when you leave the emergency department. And that's one of those things that I think about is, again, what referrals and what discharge things do you have for these folks? And then I'd like, again, for you guys to enter into the chat for me, what would be helpful to you? So this is the same question, to better support your patients who are determined to be at risk for falling in the home. So this is just, again, going through their survey, and I'm going to go back in just a second to the first slide, but what would be helpful to support this? Okay. What do you guys need in your facilities, in your area, to be able to help give your patients resources. So I'm going to go back to this first slide again. And just looking at this, a lot of people use the Morse fall scale, and you can see this is a lot of different facilities. But you had the next biggest was I'm not sure. So some people were not even sure of what fall risk assessment they used, or what that was there. The John Hopkins is the next one. And I'm going to show you a study at the end of this, kind of looking between the John Hopkins and the MedFrat scale that people use. And then you're going back up to, they use something else, and some people don't even utilize a screening tool. And I'm going to show you why that's important at a later slide. So again, looking at, referrals, these are just different referrals that can be provided. And that's why we're bringing in Allie and Pat to talk about what is out there for you. So when you are telling people that are a fall risk, when you're discharging them, you've got something to give them. You've got something solid. And then again, this is just ideas for things that would be helpful. So you can look at this and do the same thing. Would it be handouts? Would it be something attached to their discharge paperwork? Would there be like little postcards? We've given some things called, it's a prescription pad that the doctors can use to check, hey, we think you'd be good for this falls prevention program there at the hospital. So what would be helpful for you guys to give to your patients before they're discharging, again, from the emergency department? Because I feel like it's very important for us to provide them all the education that we can. And the reason being is ED referrals to falls interventions can reduce the risk of an at-home fall by 38%. So think about that. Is why is screening important in the emergency department? 38% is a big deal. It's a big number when you look at how many people are falling, what that is. So even again, if they're not coming in for a fall, if we are screening properly and identify somebody as a fall risk, and again, it doesn't have to be everybody across the board, but you guys, what I'm asking you is use that clinical judgment. If you know that somebody's really at risk, let's make sure that even if they're coming in for that headache or that belly pain, that we are really screening to reduce this, because 38% could be a huge number if we're continually screening correctly, identifying those at risk, and then giving them some sort of resource. Whether they use it or not, that's totally up to them. But 38% is a big deal. I'm just going over the John Hopkins tool, just because, again, that's something that's used at the university and the emergency department. When I looked at their age, to me, is not a predictor of health. But again, 65 and older, you're looking at that increased risk of falls. Again, fall history. One fall within 6 months before admission or before they were seen. So looking at that fall history, and again, falling once doubles your chances of falling again. So thinking about that. When they talk about elimination, so especially Ruth and I talk about this when we go out, is are they getting up to go to the bathroom 2 or 3 times a night, or are they rushing to go use the bathroom if they've been holding it? Have they been incontinent? Because obviously rushing to do things can increase the chances of falling, because you're trying to just get to that bathroom. You don't know what's in your way. And especially at night, if they don't have something well lit, they're tripping over the cat or the dog that's laying at their bed, whatever that case may be. Medications, we already talked about that. So looking at what medications they're on, using that assistive equipment. So for this one, I don't look about this because, again, if I'm looking at home risk, they're not going to have an IV when they're at home. So that's going to help me if they're in the hospital, but it's not going to make any difference if I'm just screening for home. Their mobility, do they require a cane? Do they require a walker, a wheelchair? How's their gait? How's their vision? And are they altered? What's their baseline mental status? Because again, we all know that changes. And those limitations to or people not understanding their limitations is also a big increase to fall risk. And again, this is just a big overview, guys. I could go on a long time about this stuff, but this was the next thing. So this is the Memorial Emergency Department Fall Risk Assessment Tool, which is your MedFrat. So this study was the risk of falls associated with 30-day mortality among older adults in the emergency department. And the biggest thing they looked at is actually 75 and older. If they were a high risk for falls and had a history of falling, that 30-day mortality actually really increased. So you can see along the bottom, days after departure from the emergency department, your high risk fall patients had an increase in mortality. And again, just looking, they really looked at this. 75 and older is really where it hit it with. They're moderate and they're low risk. It had some limitations. I'm not going to lie, this did have some limitations in the study that they did, but fairly conclusive of looking at there is more to be delved into. And also, what this study looked at is they felt like this was a better tool strictly for the emergency department. The John Hopkins is great. There's a lot of evidence-based falls risk assessment tools, but this one again on that right-hand side that just looks at history of falling, confusion or disorientation, are they intoxicated or sedated, and that comes in with their medications as well. What's their gait, use of mobility device like a cane, or experiencing altered elimination. So it took out that IV piece for me, because again, at home they don't have an IV usually. Can't say that not everybody does. Some people are sent home with IVs still in central lines. But looking at this again, what are they having? Is this really a risk at home for a fall? And looking at that increased mortality, it's associated with increased mortality. So thinking about that, bringing down that percentage by maybe 38% could be great. But I really would love, just to know, and you guys can reach out to me after. You can put this in our survey when we have this at the end. But really looking on how Ruth and I can help, either, across just getting with your hospital with your injury prevention, or even at the University of Utah. How can we help reduce this fall risk? How can we help you with that? And then I'm going to turn it over to Allie and then Pat to let them know how they can help you, because that was the end of mine. And I just want to bring up the chat just to look at some of the things. Yet never had training. It's what we do. Very true. All right. I like looking at the chat. But yeah, now I'm going to turn it over to Allie to talk about resources in our community. And then again, I'm sure she can let you know where you can find resources if you're not in the Salt Lake County, but looking at state. And then we'll turn it over to Pat.
Yes, hello. My name is Allie, and I work in the injury prevention program at Salt Lake County Health Department, and I am the Stepping On coordinator for the classes that we offer. That's a falls prevention class. We'll go over that in a sec. But I am also a master trainer for the Stepping On facilitators. So I do about every other year, sometimes every year, a training to get people trained as a facilitator to lead that class. So that's what I'm doing. I'm also helping out with car seat safety on the side. If you have ever known anyone in government with health departments and our programs, we just kind of wear all the hats. I'm sure you know that too, Jamie. You wear all the hats too. And Jen is my colleague. Are you ready to help with the chat, Jen?
Yes, I am.
Okay, awesome. Do you want to introduce yourself?
I'm Jen Osborne, and I work for the Salt Lake County Health Department as well with Allie, so I teach the Stepping On.
Okay, great. So here we go. Are you all able to see that?
Yes.
Okay. It says free falls prevention resources. Okay. Great. So we'll go ahead and start it off. Under the Salt Lake County overall umbrella, we have our health department, which is where Jen and I operate in the injury prevention program. And then we also have aging and adult services. So I'm going to go over both of our collaborative resources that we offer, but just know that we're kind of two separate agencies working on the same goal. It's a little confusing, but we'll figure it out. Okay, so Stepping On, that's the first thing I want to talk about. So Stepping On is an evidence-based 7-week program, and it is proven to help reduce falls. And we talk in our classes about the most common causes. And it is a group joined discussion that everybody gets to participate in. And I really enjoy facilitating, and we end up making lots of friends in our classes. So it's a falls prevention workshop, 7 weeks long. We meet once per week for 2 hours, and the facilitators and participants practice strength and balance exercises for part of each week we go over at least one or two of those exercises. In the beginning, we cover 8 overall, and they get to practice those throughout the 7 weeks. We give them a little log, a sheet that they check off, and they keep track of how often they're doing those. And then we also discuss the risks of falling, how to recognize those, and kind of create a plan to stay upright as we're going along. They find out what's important to them, and then they take those things that we learn in class and apply them at home. We also use volunteers, professionals that come in and speak on different topics. Just like Jamie showed us in her presentation, those common causes like the balance and strength, vision, community safety, and medication risks. So we have experts that come in to talk about all of those topics in our class. Our facilitators also use adult learning strategies that are proven. It's an evidence-based curriculum, and it is shown to reduce falls by 30% or more. But Jen and I have found that it actually, for us in our community, has reduced them by a lot more than that. So who is Stepping On for? This program is for adults who are at a risk for falls. They're afraid of falling. They've fallen before and they're afraid to do it again, and they have fallen one or more times. So anyone who has that criteria can come to our class. The program is for adults who live independently. We want them to be able to move around pretty unassisted because we only have Jen and I in the class usually, and maybe one other expert there with us. And so if they can, for the most part, get around on their own, that's the best situation for us and for their safety. We don't want them to use a walker, scooter, or wheelchair most of the time indoors, so that kind of helps. If it's someone like that, you would want to look at a different program. And then you want them to be cognitively intact because we use a lot of verbal discussion in our class, and that can be hard for someone that's not cognitively there. And then this program does not have an age requirement. They did away with that, and I think it's awesome. We've had 40 to 50-year-olds in our class that are daughters of our participants or sons, and they really get a lot out of the class, even though it's not necessarily targeted towards that age group. It's more targeted toward older adults. But like I said, they take those things in class that apply to them home, and they found it to be valuable also. All right, so how do we find this workshop? We would go to Healthy Aging. This is just for Utah. We would go to healthyaging.utah.gov and click on Find a Workshop. The space is limited for Stepping On classes, so there's only 14 spots per class. So they do have to register, and they can search. I have a screen right after this that will show what it looks like, but they can search for Stepping On and narrow it by zip code. And it's in person for the most part, but there is occasionally virtual options as well. So here's a screenshot of that website. So you can see right up at the top left, I put in a Salt Lake City zip code, and underneath it just shows what is nearby that's coming soon. So we have a couple classes in the area coming up. You would just hit register and then be able to sign up for the class. And I wanted to include this. Jen and I compiled these quotes from our participants. I'll just read a couple. I liked the one where it says, "I'm more aware of my surroundings in preventing falls because of this class. This class has made me more aware of falling hazards around my home and indoors and outdoors. And I have stronger muscles, and that feels good." But there's a lot. There's a lot of good positive feedback that we get from our classes. And oftentimes it's by word of mouth. So I think it would be valuable to ask people who come in, if they already have done the stepping on class, maybe have you told someone about it? Might be a good follow-up question. Okay, so these are other local classes that may help reduce falls, and these are offered throughout Salt Lake County. So the first one up top is Tai Chi, and that is a very low impact program that is great for balance. Silver sneakers, especially the silver sneaker stability class, is great for balance as well. And that can be offered to our older adults over 65 at no cost through Medicare. So if they're going to the rec centers and taking those classes, then they can come into the class for free. The Walk with Ease program is also offered at many of our senior centers and sometimes at our rec centers. Those would be on the Healthy Aging website as well. And that helps with arthritis. So if they're not getting up, not moving around, they're at home, like Jamie was saying, that's a risk factor, staying home, then they can get up and increase their activity because they take that class and learn how to manage that pain. Enhanced Fitness is also a great falls prevention focused program. They developed it just for falls prevention, and it promotes physical activity along with social stimulation because being alone is also another of those risk factors for falls. Balance and fall prevention exercise class, that is only at Mount Olympus Senior Center that I know of, but I do know that they have that and they cover just specifically balance and strength for preventing falls. So that is where those are offered: senior centers, the Healthy Aging website, at our rec centers, and then online searches for silver sneakers. They do have them online. And then there are some virtual options on YouTube and some different platforms that you can look up classes as well. All right, this is a bonus resource. So Jamie was saying I might have one that's for people who are not in Utah, and this is a great one. So this is called the Falls Free Checkup, and it's by the National Council on Aging, and it tells you what your risk is for a fall. So it asks several questions, and you just fill it out. It takes 2 minutes or less, and then it comes up with a score. So it tells you whether you're low or high risk for falls. And that is just on the National Council on Aging website. Okay, well, that is our contact information for me. That's me, Ali Tedrow, and then Jen's contact information as well. And then Marianne is with Aging and Adult Services, so she can connect with you about the senior center specific questions about classes and things like that. So I did send this to Jamie. Are you able to send this out? Okay,
Yes, I'll be able to send that out.
perfect. And I am going to have Jen add these links into the chat here. And
Done.
these
They are there.
Okay, awesome. These are just all of the links relating to what we talked about. If you want to learn more, the link to register for classes that are offered in Utah, and then all of those fitness classes options as well. Jen, do you have anything to add?
No, we would love to spread the word though about Stepping
Yes.
On. It's a fabulous program, and I think we would have a hard time teaching it if we didn't really passionately believe in it. So it's a great class, and we've seen lots of results. So please spread the word.
Thanks, Jen. Okay, that is it for me. I am there we go. I lost my stop share button. There we go. I found it.
Nope, that's okay. And Ruth had asked if you guys are aware of anybody in Utah doing bingo size.
That is a great question. That is not something that we offer right now. I know it's been discussed, especially in our coalition, which, by the way, if you're interested in that, reach out to me. It's just for Salt Lake County for now, because the bigger we get, the harder it gets to be managed. So just Salt Lake area right now. But hopefully we can add more coalitions in the future.
Fantastic. All right, I am going to turn it over to Pat, let him introduce himself. and what he does, and then we'll open up for questions for everybody at the end. So Pat, I will turn it over to you.
Okay. Can you hear me? Okay. Thanks for having me. And I'm speaking on behalf of, at this point, an 8-person team working for Salt Lake City. Our team currently is called Chat. I have there's no indication that that name will change in the future, but it's possible. You never know with changing administrations. But to give you a little background, my name's Pat Fraser. I've worked for Salt Lake City Fire for just under 10 years. Most of that time was working at Station 2, which is right by West High downtown. So it has a number of demographics that particular dual company house serves. But my role, and I think this is important to give you some kind of context into the reason why I'm working on the team that I'm currently on. But I think one of the characteristics, the nature of EMS, is that often we get patients that we refer to. I mean, I'm sure there are a number of different titles, but we call them frequent flyers, where we respond to that resident or that patient for a fall. That's often one of the reasons we're going there repeatedly. And thankfully, our administration had recognized this issue that's been ongoing probably since the onset of the EMS, since EMS started. And they said, we need to have a way to follow up with these patients that don't necessarily need an ER visit, although some of them often do. But 2 years ago, they introduced this program called CHAT, stands for Community Health Access Team. And that it opens the loop back up, where before we'd do our report, we'd send it to the Bureau of EMS, and that report goes into the ether, and then that person just gets put back into bed or picked up out of the tub, whatever the reason for the fall was, and we move on to the next call while that person stays in a home that maybe has too many throw rugs or doesn't have enough of those structural elements like handrails by the bathtub or the toilet. So all these things that we knew they needed, but we couldn't provide, now introduce Chat, we can respond to our patients, our clients' homes, and actually do a little more thorough assessment. Thankfully, we've brought social workers into the mix. I work with 2 of them pretty closely and 1 other firefighter. And we can do a bit more of a thorough assessment of the patient's surroundings, their family involvement, what resources they have, what insurance they have. And often my role on this team is introducing home health. That's primarily what, at least currently, what my role consists of. If they have private insurance, Medicaid or Medicare, we can bring that healthcare, physical therapy, often hospice, and any of those needs that their insurance can cover and that these home health companies offer. We can pass that case onto those companies and they get that healthcare in their home. So I just ran a report before the meeting, and over the last 1.5 years, we've had at least dispatched coded as falls, and a number of those we are currently managing or have managed. I've only been on this particular team for about 6 months, and a large portion of our call volume or our referrals are for patients that fall. I would say overwhelmingly it's in the elderly population, the geriatric patient. And our resources, although we do have a lot of home health companies, we do often deal with patients that don't, perhaps I'm thinking of one patient most recently that had some pretty negative experiences with healthcare, and whether or not her anxiety or issues with healthcare were valid. Maybe they were just more of a delusion or not. Whether or not that is the case, we having resources like what Jen and Ali presented that are more community based. These are things, I mean, I wrote this note down, like these are things that we can incorporate into our list of resources that we can offer these patients and clients. So in summary, I think historically, like I said, that closed loop where the patient just exists in this contacting EMS, occasionally getting transported to the ER. Now there's another avenue where we can direct the direction of those calls can change, and maybe the frequency with which our crews are contacted to help this person off the toilet, for example. Those are slowly diminishing, and we've been seeing that. I think anecdotally, I can certainly say that those frequent flyer calls have diminished, and our crews are giving us feedback stating such. But as of now, we don't have statistics to support that, but it seems like that's the trend, that we are addressing the actual need and not just keeping them in that loop of EMS, ER, EMS, ER. I think because this is a new program, often when we discuss this chat crew, people have no idea that we exist. And I think one way in which we can be helpful is Ali and Jen. I think I'm planning on adding the stepping on and falls free checkup to our list of resources that we can offer these clients and patients that we contact. And also, not only that, but we can actually reach out to patients. If we get a referral, often that's via email, that's from our crews. We have a process in which we can refer them with the software that our EMS crews generate medical reports. We can network and get involved in programs like this where we can reach out to patients, whereas historically the patients need to come to the ER. We can actually go to their residence, or if they're unhoused, we can meet them where they're at, quite literally. Unless there are questions, I'm not really sure how to do that, or how to address that. I'm assuming it's in the chat, but I can post my contact info. And if there are any questions, reach out. I'm one person on a team of 8 of people much smarter than me and more deft in this world. I'm still learning quite a bit every day. So we're on a team, and we can address most any question or issue that pops up. So like I said, repeating myself at this point, I'll post my contact info and reach out if Ali, if you think that's the best route to, yeah.
Yeah.
Okay. All right, I'm going to mute myself unless Jamie or Ali, you have any questions for me.
Nope, I'm going to open it up to everybody.
Okay.
I have a couple of questions just because that always pops into my mind, or comments, but open it up to the rest of the group. If you guys have any questions, feel free to come off mute, put it in the chat, for myself, for Ali, or for Pat.
Pat, I have a question. Do you guys ever go out to the senior centers and talk to them about what you guys see as firefighters and EMS, and just kind of give that basic rundown of how they can prevent? Or do you have another location that you've found that you get together even with people preemptively before they're on your docket first as a call? I hope that made sense.
That was a question for me, yeah?
Yes.
Okay. So that what you just described makes a lot of sense. However, I think what EMS does well, or what they do best, is just respond to the emergency. I know technically the community outreach would be great, but often
Yeah.
It's lacking for a variety of reasons, and this is my stance. I don't know this, at writ large this applies, but that's something that I think that we have a new wing of our administration that focuses on that community outreach more and more every year. That particular instance, no. And I think that it comes down to the way that we're trained and the way that we come up through the process of being an EMT. It's very much addressing the emergency that's right in front of you. So we have very limited tools. It's like the alert and oriented ×4, the Glasgow Coma scale. I'm only aware of the Braden or the Morse Falls scale just because I have dipped my toes into the nursing education world, had never heard of that before. And I would imagine that a lot of my colleagues, EMTs and paramedics, have pretty limited exposure to it unless they've been tasked, through their department in some way. So we're limited there. And I tend to be a little verbose. So I think that we're limited. However, that is something that our team can do. And I think they're trying to expand I think the team's ability. Right now, we're limited by personnel, but I think that is a great suggestion and something where we could do a better job.
Patrick, real quick, Janae Mortensen with Aging and Adult Services. I can connect you with her, but I know she has worked with fire departments with education. Do you know of her? Maybe. But she can work with you on getting education about falls prevention specifically.
Yeah, and Ruth just put she had never heard of chat. And that's one of the reasons why I was really excited, Pat, that you could join us today. Is I really think getting that exposure out there and people knowing that there are these community teams with EMS that are responding to those frequent flyers, that are helping to reduce not only your call outs, but also I think reducing visits to the emergency department. I know we've got a couple of other agencies throughout the valley that have some of these teams. And I really do think it's important to know that you guys are out there. And then the other question is to ask, or let you know that any way that I know the hospital systems, especially myself as an injury prevention person, Ruth is an injury prevention person, and then in some of our other hospitals are always a resource and want to be helping. If we're the ones that are putting it out there and doing that community outreach and we're just helping you guys, that's what we want to do. We think this is a team sport. Injury prevention is a team sport. There are so many components of injury prevention and so many key players. And so that's why I love this platform, where bringing together two key players in the injury prevention world with Ali and with Pat is a big deal. Letting people know what's out there, what people are doing for injury prevention, and to keep people out of the hospitals. So I open it up if you guys have any other comments or if anybody else has any other questions.
I think that's exciting that you're already seeing a difference in your numbers, Patrick. You're doing a great job. Thank you.
Thanks. Yeah, I agree. And like I said, I think it's anecdotal at this point, but the program's only been in existence for about, I think it's just under 2 years. And they're constantly, as you can imagine, the way that new programs go, they're still evaluating if this is currently there are two directions that this team is going. One is a scene response, where primarily they're managing back on the hook. Oh yeah, thanks for posting that, Jamie. The we're responding. We have a scene response, and that's where actually we've got 4 social workers that ride with the medical crew, provide services, social services at cardiac arrests, overdoses, and such, getting people enrolled into bridge programs. The second one is the one that I'm part of, where we do the follow-up. So our crews will refer the frequent flyers, and we'll follow up at that patient's residence. So they're still trying to examine which is the most effective. A lot of these programs, at least that have started up around the country, they seem to have had varying levels of acceptance and like demonstrable progress in those 2 areas. So Salt Lake is still trying to figure out which is the best route. So I'm a bit partial. I think this follow-up, especially being in the field for as long as I was, it seems like the most beneficial, these follow-up. And I really welcome any sort of any resources that anybody can offer us. It's like, it's so beneficial because of the myriad obstacles that our patients have, whether it's access or insurance or mental health issues, fears, anxiety. So the more resources we can provide and the more networking we can do at this point, it's going to benefit us, the program, and the community as a result. So thank you. And yeah, maybe next time, Jamie, I hope to have like numbers and graphs that we could demonstrate, statistically.
No, to me, I mean, you don't need to see that. I think just being able to hear what you guys do is huge. And then just one other thing that popped into my head is we recently got information about some grant funding that's coming available specifically for home improvements for falls, as Allie's looking at that, because I saw the same one and I actually thought of your team and the teams that are doing this across the county of, how can we help? Can we get grant funding? Because how do you guys fund? Do you need to put in grab bars or getting PT or things like that? Is there funding? Is there just referrals? Is that something that would be beneficial? I know we're kind of ending time, but just from your experience, what kind of things as far as that for funding would be beneficial to your team?
For us, it's personnel, like having more people to be out there educating. So we don't really go into the homes. We don't have the time for that and to do grab bars and things like that. I know Sandy Fire does some of that, but yeah, as far as going into the home, aging and adult services, Marianne, I don't know if you can hop on and talk about that at all, but they might be able to do something on the phone. I'm not too sure. Maybe she can pop on, but yeah, we just need more personnel funding is what we are always looking for.
If you guys aren't reading it from Annette, patients that are reluctant to do home safety evaluations through OT, she offers to mail the CDC check for safety, the steady brochure, just kind of planting that seed of looking for there. Like Pat had said, there's a lot of people that are wary sometimes of hospitals for whatever reason. So for me, any resources that I can provide people, any help that I can give as far as myself and Ruth. And again, I can tell you any injury prevention person that's on here. I'm going to pick on Allison because I'm sure that she would love to have all the funding and do all this stuff too in her area. But for all of us injury prevention folks that do this, always happy to help, always happy to see what we can do to help. Like I said, I know we're over time, so I will be posting this recording on our YouTube site. For those of you that are here, like I said, we'll be sending you a follow-up just survey for this evaluation, and then you guys will get your certificates. And then we hope to see you guys again soon. Pat, I'm sure that we're going to be in contact again in the future. And then Marianne just put Assist Utah will help install grab bars. So just a lot of things to be thinking about in the future, a lot of things to be doing. Again, like Annette said, networking and helping this vulnerable population, especially to falls and injury, hopefully reduce that. So thanks for everyone for joining us, and we'll see you again next time.
Thanks, Jamie.
Mm-hmm.